Good evening, everyone. It gives me immense pleasure to welcome you all to this evening scientific session. And I take this opportunity to thank our faculty and the participants who have taken their busy schedule to join today for this webinar. Today's webinar, as we all know, it is focusing on SGLT2 inhibitors. We all know that SGLT2 inhibitors were developed initially for their glucose lowering effect, and in the past decades, we have seen series of large, robust clinical trials which have demonstrated striking benefits of these SGLT2 inhibitor for various care goals, transforming the chronic disease therapeutic landscape. So today's webinar focuses on the evidence of SGLT2 inhibitors from type 2 diabetes, renal, cardiovascular outcome trials, and heart failure trials, and also discusses ongoing research related to their use in cardiovascular disease. And to take this session forward to help in conducting our session, we have our moderators. Can I have the slides, please? Who are going to help us in conducting this session. Our global chairperson for this scientific session is Professor Ogala. Professor Ogala is a very eminent cardiologist from Kenya. He is the president of PASCAR National Council and also chairman of Department of Clinical Medicine, University of Nairobi. I thank Professor Ogala for accepting to be the chairperson for today's scientific session. Welcome you, sir. And to help us in next slide, endocrinology perspective, we have endocrinology expert with us, Dr. Lumo William. Sir is president of Uganda Diabetic Association, vice chairman of UNCDA, and senior lecturer, Uganda Christian University. Sir will be endocrinology expert and helping us in conducting this session as a global moderator. Welcome, Dr. William, sir. To give the nephrology perspective, and nephrology expert on board today is Professor Lowa. Sir is the General Secretary of Malagasy Nephrology Society and board member of Malagasy Cardiology Society and also member of Francophone Nephrology Society and Dialysis and Transplantation. And Sir is also going to help because we have some participants doctors who have joined us from Francophone countries. He'll help us in helping us in some amount of French translation as well. So I welcome all our moderators for helping us conducting this session. Before we start the scientific session, I request Mr. Sanjeev Saigal. He is our okay senior vice president to briefly tell about microlabs.
Thank
Over
you,
to
Dr.
you, Mr.
Manjula.
Sanjeev.
Thank you, Dr. Manjula. Good evening to you all, dear Professor John McMurray, Professor Ogola, Dr. Lomo William, and Professor Lowa, and all other participants. I'm delighted to be here today representing Microlabs Limited, a multinational company based in India. As the Senior Vice President taking care of East Africa region, I would like to extend a very warm welcome to all of you and express my gratitude for accepting our invitation. It's a pleasure to see such esteemed professors and doctors present here from more than 18 countries. Microlabs Limited was established in 1973 and is headquartered in Bangalore, India. We are engaged in development, manufacturing, and marketing of pharmaceutical formulations. With a presence across globe, our state-of-art manufacturing facilities have received approvals from recognized global authorities such as US FDA and UK MHRA. We serve a wide range of therapeutic segments, including cardiology and diabetology, gastrology, and general health products. In the East African region, we are well established in the field of cardiology and diabetology. Microlabs is driven by the belief that knowledge is power. We actively participate in several scientific programs, and this event is one of them. Our commitment to learning and sharing knowledge is unwavering, and we will continue this journey. Finally, I would like to express my sincere gratitude to each of you for your valuable participation. I truly believe that together we can make a meaningful impact in improving the quality of life of our patients. Thank you very much.
Thank you,
Over to
Mr.
you, Dr.
Sanjeev.
Manjula.
Thank you, Mr. Sanjeev. May I now request Dr. Lomo and Professor Lova to introduce our regional moderators. Over to you, sir.
Thank you very much, Dr. Manjura. I take this opportunity to welcome all the delegates who are going to attend this webinar. The way we are going to do it, I'll be introducing the regional moderators from the Anglophone countries, and my colleague, Professor Loa, will be introducing those ones from the Francophone. Now, I'll start from Kenya. Start with Kenya. In Kenya, we shall be joined by Dr. Paul Nguji. Dr. Paul Nguji is a consultant physician, endocrinologist, and diabetologist from Nairobi, Kenya. He has had several decades of practice in internal medicine and diabetology. Then we shall have Dr. James Kaima. Dr. James Kaima, he's a physician, he's a cardiologist and a senior lecturer from Makerere University, and is an interventional cardiologist from Uganda Heart Institute. Welcome, Dr. Kaima. Then from there, we shall have Dr. Sood Mohammed. Dr. Sood Mohammed is a consultant physician and nephrologist from Kenya. From Mombasa, Kenya. You're welcome, Dr. Sood Mohammed. We shall also have Professor Mohammed Yakub Janub, is from Tanzania. She's the Chief Executive Officer from Muhimbili National Hospital, Tanzania. We shall also be joined by Dr. Constantine Aquanalo. Dr. Aquanalo is a consultant physician, cardiologist from Eldoret, Kenya. And from, I think those are the ones from the Anglophone. For now, we take Rwanda to be Francophone, and I'll be asking my colleague, Professor Loa from Madagascar, to introduce the regional coordinator from Rwanda and, of course, Mauritius. Over to you, Professor Loa.
Go to previous slide, please.
Yeah.
Can you hear me?
Yeah, we
Yes,
can
I
hear.
can hear you.
Thank you so much, Dr. Lumu. So we are three French-speaking countries participating to this event. We have colleagues from Mauritius, and waiting for the slide to introduce them.
Sir, from Rwanda.
Okay, the first one is from Rwanda, Dr. Bavuma Charlotte. She is an assistant professor of IM and endocrinology at the University of Rwanda. From Mauritius, we have Dr. Suko, consultant interventional cardiologist. And from Madagascar, I am Louva. I'm a nephrologist. I'm a professor at the Antananarivo University and member of the Cardiology Board of Madagascar and the Society, General Secretary of the Nephrology Society of Madagascar. It is a pleasure and an honor for me to participate to this event. And we are excited to hear from Professor John McMurray about SGLT2 inhibitors. For it was the biggest event in nephrology in this 3 or 4 last year for Madagascar.
Thank you, Dr. Lumo and Dr. Professor Loa. May I now request Professor Agola to introduce the speaker of the day, Professor John McMurray. Over to you, sir.
Yeah, thank you very much. As has been introduced, my name is Elijah Gola. I'm from Kenya University of Nairobi. I happen to be the current president of the Pan-African Society of Cardiology. So I really wish to thank Microlabs for organizing this regional online meeting on a very important subject. As we all know, failure is a major cause of morbidity and mortality globally, probably the only cardiovascular condition that is increasing both in incidence and prevalence. It is associated, like I've said, with considerable morbidity and mortality, but also with considerable healthcare costs, which those of us in the less endowed economically parts of the world can hardly afford. And unfortunately, in our circumstances, we have heart failure affecting younger people, having higher morbidity, higher mortality and morbidity. The story of the treatment of heart failure is long. I think I'm one of the older guys here, so I was already working as a consultant when the first trial that showed that you could actually impact mortality in heart failure, the consensus trial was published in 1987. We all know the story of the neurohumoral inhibition after that with the ACE inhibitors, ARBs, beta blockers, MRAs, etc. So to take us through this journey and take us through the development subsequently to that, which is basically with ANIs and SGLT2 inhibitors, is somebody who has been part of that journey right from the beginning, and that is Professor John McMurray. He has told me to make sure that I summarize his introduction, which is a task that is easier said than done. Professor John McMurray is Professor of Cardiology at the University of Glasgow. Is a consultant cardiologist at the Queen Elizabeth University Hospital. Anybody who is involved in cardiology, especially in heart failure, knows his involvement in the various landmark heart failure trials from term added in the early 2000s to emphasis later in the late 2000s to Paradigm HF. I listened to you live in Barcelona in 2014 when you presented this. It was the first time that we were getting anything new that impacted mortality in heart failure. And subsequently, he's been pivotal in the heart failure trials in this new wonderful class of drugs, the SGLT2 inhibitors. He's published widely. He's received many honors, including being knighted by Her Majesty, the late Queen Elizabeth in 2019. So I could go on and on and on, but my job today was simply to give an introduction. It is my pleasure to invite Professor John McMurray to give us his lecture. Welcome, Prof.
Thank you very much, Elijah. So I'm going to now try and share my screen. So I'm worried after an introduction like that people will have high expectations and I will not deliver on those. But let's see what I can do. So good evening, bonsoir, everybody. Thank you very much for coming to listen to this presentation. I apologize that I don't speak French. In fact, my friends here tell me I don't really speak English very well either, because I'm an Irishman living in Scotland and we've got a very strange accent. So I hope you can understand everything that I say. And I have the massive problem of trying to get through, as you heard earlier, really 10 years of the most remarkable findings with this new class of drugs. And although my major interest is in heart failure, and I will talk a lot about heart failure, I'm going to try and cover the whole story of SGLT2 inhibitors. So I'm going to talk about the trials in diabetes, trials in kidney disease, and the trials in heart failure. Although, of course, we know that it's a bit artificial to try and divide these patients by just having one of these diseases. Many of our patients have all three of these problems overlapping. So these are my disclosures. And some of you will have heard the expression, which is very popular in the United Kingdom, where I live and work, an apple a day keeps the doctor away. And that's very relevant to what we're just about to talk about, because the drugs that we're going to talk about are actually very similar to a chemical derived from the bark of the apple tree, and that chemical is fluorescein, and fluorescein was really the first inhibitor of the sodium glucose co-transporters. So these drugs, as you know, were, and as you heard in the introduction, were originally introduced as a treatment for diabetes. They work on the selective agents, the co-transporter 2 selective agents act on this co-transporter that is found predominantly in the proximal renal tubule, where it is responsible for reabsorption of filtered sodium and glucose. If you block it, you block glucose reabsorption, sodium reabsorption, and of course, you therefore increase urinary glucose excretion. And that's why these drugs were of interest initially as a treatment for type 2 diabetes. But as we'll see in the next few minutes, they've really revolutionized the treatment of both chronic kidney disease and heart failure. But the story about these drugs goes back a really long way. In fact, it goes back almost 140 years. And I mentioned that there is a chemical that can be isolated from the bark of apple trees. It's called fluorescein. And it was initially discovered that this agent could increase urinary glucose excretion in dogs and lower glucose, circulating blood glucose levels in dogs. And a few years later, this was also tested in human beings, and fluorescein was found to have exactly the same effect. It increased urinary glucose excretion, it lowered blood glucose, and there was interest a long time ago that this might be an interesting treatment for diabetes. But in fact, fluorescein was not developed further because it caused gastrointestinal upset. It was not tolerated because of gastrointestinal side effects. And that's because fluorescein is a non-selective SGLT inhibitor. It blocks both SGLT1, which is found in the gastrointestinal tract, particularly the large bowel, and SGLT2. And the side effects, the gastrointestinal side effects, were because of its effect in the colon. Just out of interest, I was asking earlier, was cider available in the countries involved in the meeting tonight? And I understand it is available in some of these countries. Fluorescein is also found not just in the bark of apple trees, it's also found in the skin of apples, and it's found in that alcoholic drink that is made from apples called cider. So if you drink cider, you will get some SGLT2 inhibition. So this is the timeline, and really the whole story of selective SGLT2 inhibitors came about in the late 1990s. By the end of the first decade of the 2000s, the first selective SGLT2 inhibitor that could be used in humans had been discovered. By 2015, we had the first of the large cardiovascular outcome trials that I'm going to talk about. And by 2019, we had the first heart failure trial. So once these drugs were developed, the use of them in trials and the discovery of their effectiveness was extremely rapid. It occurred very, very quickly. And that's the history that I'm going to take you through the past 9 years or so. Now, because there's so much to cover, I can really only give a bird's eye view. And again, I also apologize. I'm a cardiologist. I'm not a diabetologist. I'm not a nephrologist. So I maybe won't say exactly the right things about the evidence in diabetes and nephrology, but we've got a panel of experts who will talk about diabetes and nephrology later. So I'm going to start with the diabetes trials. I'm going to look at them from the point of view of these being trials where SGLT2 inhibitors were shown to prevent cardiovascular events and specifically to prevent incident heart failure, new onset heart failure. And between 2015, that very first trial, and 2020, over a 5-year period, we saw in quick succession 4 large randomized cardiovascular outcome trials using different agents in this new class. And you can see the summary of the details of these trials on this slide. So they were between 7 and 17,000 patients in size. They're all placebo-controlled trials. And you can see here, as I said, different agents in this class. And it is worth recalling that these trials were actually conducted because the US Food and Drug Administration was concerned about the safety of glucose-lowering drugs in patients with type 2 diabetes. And actually, ironically, the first large randomized trial I ever did in patients with diabetes actually showed that a drug called rosiglitazone significantly increased the risk of developing heart failure. So these were cardiovascular outcome trials done predominantly to demonstrate the safety of this new class of glucose-lowering therapy. But in fact, instead of just demonstrating safety, these drugs showed reduced cardiovascular risk. But it wasn't a reduction in the composite cardiovascular outcome that the US Food and Drug Administration were interested in, so-called major adverse cardiovascular events, or MACE. That's a composite of cardiovascular death, myocardial infarction, or stroke. The striking benefit was on heart failure hospitalization. And you can see here in all 4 of these trials, there was around a 30% reduction in heart failure hospitalization. There was a small reduction overall in major adverse cardiovascular events, but the major effect was on heart failure hospitalization. And again, the striking thing here was how consistent this benefit was in all 4 of those large trials. Now, you can imagine that I, as a cardiologist interested in heart failure, was really astonished when I saw these results coming through. And as soon as we saw the first of these trials, the EMPA-REG outcome trial, I was talking to various pharmaceutical companies about the possibility of doing dedicated heart failure trials, and I'll come on to those in a few minutes. And I've said the results were very consistent. You're going to hear this word over and over again about this new class of drugs, because everything we've seen about these drugs is consistent effects in different trials with different agents, consistent effects on endpoints, consistent effects on subgroups of patients. So you'll hear me say the word consistent quite a lot. So, and I want to move on to the trials in patients with chronic kidney disease. Now, of course, my interest here is in prevention of cardiovascular events, and in particular, prevention of heart failure. But of course, these were trials designed to show a reduction in kidney outcomes. And you'll see in the next few slides that these drugs were, in fact, extremely effective in reducing kidney outcomes as well as heart failure. And once again, we have 4 large trials. And you can see here that they range between around 4,500 patients to 10,500 patients. And once again, these trials used different drugs in this broad class. This particular trial actually used a combined SGLT2 inhibitor called sotagliflozin, and you'll see that there were some issues about this trial, and in fact, it doesn't actually have kidney outcomes, but it does have cardiovascular outcomes. But when it was initiated, it was designed to be a kidney outcome trial. So the first of these trials to report was the Credence trial, reported in 2019. I focused on this slide on the cardiovascular outcome, a composite cardiovascular death or heart failure hospitalization. And in these people with type 2 diabetes and chronic kidney disease, you can see that there was a 31% reduction in this composite cardiovascular outcome. And in fact, there was a 39% reduction in the risk of heart failure hospitalization. So once again, this is the outcome that really attracted my attention. But of course, this trial was really looking at kidney outcomes. And you can see here from this KDIGO heat map that the patients who were enrolled in Credence were very different than the patients who'd been enrolled in those earlier diabetes trials. So in those earlier diabetes trials, indicated by these letters over here, you can see that the patients largely had preserved kidney function. Very few of them had any significant urinary increase in urinary albumin excretion, whereas of course in the Credence trial, patients not only had a reduction in eGFR, but many of them also had a substantial increase in urinary albumin excretion. And not surprisingly, in the Credence trial, there were many more patients who had end-stage kidney events. These are the number of patients in the Credence trial compared to those earlier type 2 diabetes trials who required renal replacement therapy. And you can see that the Credence trial obviously recruited patients with much higher renal risk. And you can see that the primary kidney composite endpoint was reduced by 30%. This was a highly statistically significant benefit. You can see here the components of that kidney outcome. And what I've highlighted by this arrow at the bottom of this forest plot is what I regard as the hardest kidney outcome. In other words, requirement to start and remain on dialysis to have a kidney transplant, or in a very few cases, to die from end-stage kidney disease. And you can see that even this hard composite kidney endpoint was significantly and substantially reduced by an SGLT2 inhibitor in this trial. So in this trial, both a reduction in cardiovascular events and a reduction in kidney events. I mentioned the SCORED trial with sotagliflozin, this SGLT2 inhibitor. This trial was stopped early for various problems to do with funding, so it really didn't run long enough to examine kidney outcomes, but it was a large trial and there were a large number of cardiovascular outcomes reported and analyzed. And here you see again a composite of cardiovascular death or worsening heart failure events. And you can see this very striking difference between the two treatment groups. The patients getting this drug called sotagliflozin had a 26% highly significant relative risk reduction with sotagliflozin in this composite cardiovascular outcome. So a second trial in patients with chronic kidney disease showing a cardiovascular benefit driven predominantly by reduction in heart failure events. And remember, in most of these patients, this was new onset heart failure. There are 2 more chronic kidney disease trials with SGLT2 inhibitors, and these, I think, are the much more interesting trials because they both included patients without type 2 diabetes. So all the trials I've shown you so far, the 4 type 2 diabetes trials, the 2 chronic kidney disease trials, only enrolled patients with type 2 diabetes. Now we're going to look at 2 trials that included patients with and without type 2 diabetes, the Dapapride trial and the EMPA kidney trial. So Dapapride was a trial I was lucky enough to be involved in, and in this trial, as you can see, about 1/3 of patients did not have type 2 diabetes. By the time we designed Dapapride, we'd learned a lot more about the safety and effectiveness of these drugs. And we had gone from being concerned about them possibly causing kidney problems to realizing that they are nephroprotective. So in Dapapride, shown here by the blue star, we were able to reduce the EGFR limit. So we had a lower limit, EGFR of 30. So the patients in Dapapride had a much lower average EGFR than the Credence trial. They had around the same level of albuminuria. And again, obviously, with a low EGFR and a lot of albuminuria, you can imagine that there were a lot of CKD events, people requiring renal replacement therapy. So this is the primary endpoint in the Dapapride trial. This was a composite kidney endpoint, and I won't read out the different components of that composite endpoint, but it was reduced by 39%, an extremely significant p-value, a very small number needed to treat, only 19 patients for the average duration of the trial to prevent one of them developing this chronic kidney disease outcome. So very large relative and absolute risk reduction. The most interesting finding of all in terms of kidney outcomes was that the benefit was at least as large in patients without type 2 diabetes as in patients with type 2 diabetes. And although this was only 1/3 of patients, you can see that even within this subgroup, there was a statistically significant benefit of dapagliflozin. So a really, really important breakthrough in patients with chronic kidney disease without type 2 diabetes. But the most striking finding of all was this one, which is that we saw a reduction in all-cause mortality. It was very clearly statistically significant. And although cardiologists are used to seeing reductions in mortality in our trials, seeing reductions in mortality in most other disease areas in medicine is pretty unusual. And this, in fact, was the first ever drug to reduce all-cause mortality in patients with chronic kidney disease. So I think it is fair to say that this really was an important breakthrough in patients with kidney disease. And of course, as we were now beginning to expect, once again, we saw a large relative risk reduction in the primary cardiovascular composite outcome. Once more, 29%, around 30% relative risk reduction in the composite of cardiovascular death or heart failure hospitalization. So again, more evidence of both cardiovascular and very clearly kidney benefits with these drugs in patients with chronic kidney disease. And the last of the 4 chronic kidney disease trials to report was the EMPA-KIDNEY trial. This trial pushed the envelope even further. So now instead of requiring patients to have both a reduced EGFR and substantially increased urinary albumin excretion, the EMPA-KIDNEY trial included people with a low GFR and relatively low levels of albumin excretion in some cases, and almost half of the patients enrolled in the EMPA-KIDNEY trial did not have type 2 diabetes. So here again in this heat map, you see the EMPA-KIDNEY patients. You now see that the EGFR has been pushed lower down to 20 mils per minute. And you can see here patients were included with low levels of urinary albumin excretion. So this is really trying to expand the potential kidney population eligible for this type of treatment. So here's the EMPA-KIDNEY primary outcome. Again, this was a composite kidney endpoint. I won't read through the components of that, but once more, you can see a 28% relative risk reduction. Again, this was highly statistically significant. So this is now the 4th consecutive trial with different agents in this class showing a benefit of an SGLT2 inhibitor in patients with chronic kidney disease. In fact, overall in this trial, although there was a strong trend to reduction in cardiovascular events, it wasn't quite statistically significant, but the number of events was relatively low because so many patients in this trial were at low cardiovascular risk. Remember, low albumin excretion in quite a few patients, and almost half the patients didn't have type 2 diabetes, so their cardiovascular risk was relatively low, but nevertheless, the trend was in the right direction. So before we move on to finally the heart failure trials, we can conclude from the 4 kidney disease trials that in 3 of them that reported kidney outcomes, we saw a very clear reduction in progression of kidney disease to end-stage kidney disease to kidney failure. And this benefit was seen in patients with and without type 2 diabetes. And in all 4 of these trials in patients with chronic kidney disease, we also saw a reduction in worsening cardiovascular events. We saw a reduction in incident heart failure in patients with and without type 2 diabetes. So we've now looked at 8 large trials with different agents in this broad class, covering first type 2 diabetes, then chronic kidney disease, and in a moment I'm going to move on to talk about finally the heart failure trials. Now you may be wondering why I was focusing so much on heart failure in the chronic kidney disease trials, and this slide illustrates why I think it's extremely important that we emphasize the heart failure benefit in patients with chronic kidney disease. This is a slide I've drawn from an older trial we did many years ago, but I could draw exactly the same slide from many other trials. And this is looking at the different types of events that occur in patients with type 2 diabetes and chronic kidney disease. So here's myocardial infarction, here's stroke, here's end-stage kidney disease, here's heart failure. And the first thing to notice is that actually in this trial called Altitude and in many other chronic kidney disease trials, the single most common adverse cardiovascular or renal event is actually heart failure. More common than MI, more common than stroke, and actually more common than chronic kidney disease, end-stage kidney disease, I mean. And then even more significantly, if you look at the black bars here, this shows you the proportion of people who die from these different causes. And in this diabetic kidney disease population, the single most common cause of death was heart failure. So, of course, it's extremely important to prevent end-stage renal disease or end-stage kidney disease. That goes without saying, but actually preventing heart failure in patients with chronic kidney disease is also an extremely important goal of treatment. And SGLT2 inhibitors prevent both of these very important outcomes from a patient perspective. There is one more kidney trial to come, which I think is worth mentioning. And the reason it's worth mentioning is that one of the most common questions we get about SGLT2 inhibitors is whether they are of benefit in patients who are on dialysis or who've had a transplant, and whether or not we should continue to give these treatments if a patient does need to go on dialysis. The answer is we really don't know, but this ongoing trial will hopefully answer some of those remaining questions, because this is a trial that is enrolling patients with a very low eGFR, patients who've had a kidney transplant and have a low eGFR, and then patients on dialysis, although it's only enrolling patients who continue to have a residual diuresis, because we think that these patients may well benefit from SGLT2 inhibition. So watch this space. There's more to come in chronic kidney disease. So finally, what about treating prevalent heart failure? In other words, treating patients with existing heart failure. I've talked about the prevention of heart failure in people with type 2 diabetes, the prevention of heart failure in people with chronic kidney disease. What about the treatment of people who've got established prevalent heart failure? Now, I realize that the audience is mixed, and not everybody might know how cardiologists think about heart failure and classify patients with heart failure, but we've got sort of two broad categories. We've got people who've got what we call heart failure with reduced ejection fraction, or HFrEF. In these patients, the left ventricle is dilated and the contractility is reduced. In other words, the squeezing and emptying of the left ventricle is reduced compared to normal. In the other principal type of heart failure with preserved ejection fraction, or HFpEF for short, we think the main problem is with the relaxation and filling of the left ventricle. Many of these patients have left ventricular hypertrophy. Many of them have got stiff ventricles that don't relax and fill properly. Now, we've made it a bit more complicated recently. We've come up with a third category. So we now talk about patients with mildly reduced as well as reduced ejection fraction, in addition to patients with preserved ejection fraction. But this is a technicality for cardiologists. So what do we know, first of all, about the treatment of heart failure with reduced ejection fraction, patients with HFrEF? Well, again, we're very lucky. We've got two large trials, Dapapride and Emperor Reduced, two large trials in patients with heart failure and a low ejection fraction, patients with and without type 2 diabetes. And in both of these trials, patients with this type of heart failure getting excellent conventional therapy. So I'm going to show you the primary endpoint in the two trials, which is the composite of cardiovascular death or heart failure hospitalization. I'm showing you the endpoint and figures with the same y-axis panel. So this runs from 0 to 40%. And you can see that despite the fact that these are two different trials with two different agents in this class, the treatment effect is identical. There is a 25% relative risk reduction. It's highly statistically significant in both of these trials because these patients are very sick with these very high event rates within around 2.5 years or so of follow-up. The large relative risk reduction translates into a large absolute risk reduction and a small number needed to treat. In DAPA-HF, the number needed to treat is only 21 over a median follow-up of 18 months to prevent one patient having either cardiovascular death or heart failure hospitalization. And the other thing, which I'll come back to shortly, is in these two trials, you can also see this very rapid early separation of these Kaplan-Meier curves. The treatment effect begins to emerge very quickly after randomization. So I'll get my slide, seems to have got stuck for some reason. Sorry about that. Sorry. Okay, I wanted to put these findings into perspective. So I showed you at the very start the trials in patients with type 2 diabetes, and I showed you that there was a significant reduction in heart failure hospitalization and cardiovascular death in those individuals with type 2 diabetes. But if you look here, you can see the event rate in those patients in the very first trials. You can see the same event rate in patients with chronic kidney disease from the Credence trial, and here is the DAPA-HF trial. And you can see that the number of patients per 1,000 patient years of follow-up who have an event is really orders of magnitude higher. These are really sick patients. These patients with heart failure, for example, in the DAPA-HF trial, have, if you look at individuals with type 2 diabetes and heart failure, they have an event rate that is more than 10 times higher, for example, than in the Declare TIMI 58 trial. So we're talking about very sick, very high risk patients who get that large, rapidly emerging treatment benefit. Now, I haven't got time to go into all of the details of these trials. Suffice to say that when we put these trials together in a meta-analysis, which we've done, we can see that both heart failure hospitalization and cardiovascular death by themselves are reduced significantly. Indeed, all-cause death is reduced significantly. These treatments improve symptoms and quality of life. They prevent or reduce worsening of symptoms and quality of life, and they also reduce the rate of decline in kidney function over time. And remember, they're doing this when added to really good conventional therapy. We've looked at various subgroups. Of course, the one that everybody wanted to know about in DAPA-HF was the patients with and without type 2 diabetes. And just as in the chronic kidney disease trials, we saw that in DAPA-HF, dapagliflozin was just as effective in reducing the primary endpoint in patients without type 2 diabetes as in patients with type 2 diabetes. It was just as effective in patients with chronic kidney disease and eGFR below 60 as in patients with preserved kidney function. It was just as effective in patients on various types of heart failure treatment, including a mineralocorticoid receptor antagonist. And again, it's that word consistent. Every single subgroup we looked at, we saw an entirely consistent benefit. We've gone on to learn much more about these drugs from smaller trials and from further analyses of our large randomized outcome trials. And I've summarized that new evidence on this slide. Again, I'm sorry I don't have time to go through it in detail, but we've really seen favorable effects in cardiac remodeling. We see lower risk of hyperkalemia, especially in patients taking a mineralocorticoid receptor antagonist. We see correction of anemia, prevention of development of anemia. We even see reduced risk of new onset diabetes in these patients with heart failure, which we believe is a really important additional benefit of this type of treatment. For that reason, at least in the cardiology world, we believe that these drugs are exerting this sort of organ protective effect, and that's why they have those pleiotropic benefits. Very rapidly, because we have two large randomized trials giving extremely consistent results, these drugs have become one of our pillars of therapy in patients with heart failure and reduced ejection fraction, and were incorporated in the most recent iteration of the European and American guidelines. Both dapagliflozin and empagliflozin were given the strongest possible recommendation as a treatment for HFrEF. In other words, a class 1 level A recommendation. So within just a few years, these drugs had gone from initially being a treatment for type 2 diabetes to being a strongly recommended treatment for heart failure with reduced ejection fraction. And indeed, these drugs have really changed our whole thinking about the treatment of patients with this type of heart failure, because the new guidelines have also changed the way we think about using the treatments we have available. They've emphasized the importance of treating patients quickly, and that's really because of that demonstration of how rapidly SGLT2 inhibitors work. We know that they have a significant benefit, depending what trial you look at, within just 2 to 4 weeks of starting treatment. So we suddenly realize we need to give them quickly because they work quickly. We realize that because all the treatments we have work in different ways and their benefits are additive, the important thing to do initially is to get all of these treatments started. And we no longer believe we need to start in the traditional historical sequence reflecting the chronology of the clinical trials. In other words, you don't have to start with an ACE inhibitor, then add a beta blocker, then add an MRA, and so on and so forth. Because if we did this, we wouldn't be adding an SGLT2 inhibitor for perhaps as long as 6 months after making a diagnosis of heart failure. And why would you wait that long to start a treatment that is beneficial within just a few weeks of the patient receiving it? So we've had to completely rethink what we do. We now think about these drugs in this way. They all work independently of each other. Their benefits are additive. They're organ protective. They're protecting our patients. And the goal is to implement as many of these as quickly as possible. And the new guidelines are very clear about this. They even go as far as saying that we can start some of these treatments simultaneously. We don't even have to do it in the old stepwise fashion. We have modeled the evidence from the trials to try and figure out what the best way to do this is. And we find that the treatment sequence that is most likely to give you the largest benefit is starting with an SGLT2 inhibitor and mineralocorticoid receptor antagonist. I know from my own personal practice that it's possible to do this in many, many patients with heart failure, and then add a beta blocker and sacubitril valsartan, or alternatively sacubitril valsartan and a beta blocker. I don't think the next two steps really matter what order that you do them in. And I think most of us now believe that a very simple rule of thumb for treating HFrEF is really to get these 4 treatments started in 4 weeks if possible. Sometimes you can do it more quickly. Sometimes, of course, it's not so easy. But as a general rule, try and get all 4 started within 4 weeks. And really, it's the SGLT2 inhibitors that have made us realize why we have to do this. And they've given us a new sense of urgency about treatment of this deadly disease. Patients with heart failure and reduced ejection fraction have a prognosis worse than many types of cancer. Everywhere we work, everybody thinks that the diagnosis and treatment of cancer is urgent, but I don't think we've had the same urgency when it comes to patients with heart failure, but we really should have. And one of my friends in Canada lent me this slide, which I thought really was important in highlighting one of the problems that we have in medicine, which is clinical inertia. We often say, well, we'll get round to doing it someday. So, well, I'll do this one day. Really, we should be thinking about doing this on day one, because these are life-saving treatments. They work very quickly. Our patients have a very deadly disease, and really it's up to us to try and give them those effective treatments as soon as possible. So to conclude with, I want to turn to the remaining patients with heart failure who have an ejection fraction above 40%, patients with mildly reduced and preserved ejection fraction. And once again, we have 2 large trials. In fact, these are even bigger trials than in patients with reduced ejection fraction, around 6,000 patients in both of these trials. Again, different trials with different drugs, and again, trials in patients with and without type 2 diabetes. Once more, I've shown the same composite endpoint on the same scale, so 0 to 25%. So these are somewhat lower risk patients, but once more, this remarkable consistency of benefit. The hazard ratio is almost identical, 20% relative risk reduction approximately. Again, highly statistically significant. Once more, this very, very rapid separation of the Kaplan-Meier curves. You can see that almost from the day that patients get started on treatment, again, this large relative risk reduction is translated into a large absolute risk reduction. Because we now have data in HFrEF and in HFpEF and mildly reduced ejection fraction, we've been able to put our trials together, and we can look at the effect of an SGLT2 inhibitor across the whole spectrum of ejection fraction in more than 11,000 patients. We published this a couple of years ago, and we saw something that is really unprecedented, and that is that the treatment effect was consistent across the full range of ejection fraction. This dark blue line is a continuous hazard ratio. These are the 95% confidence intervals. This is ejection fraction. If the hazard ratio here is below 1, shown by the horizontal black line, that indicates that dapagliflozin is better than placebo, and you can see that the treatment effect was consistent across the whole spectrum of ejection fraction. And this is unique. We have not seen this with any other type of treatment. Here are similar analyses done with the other neurohumoral agents that we have for heart failure. And you see that with all of them, the benefit is attenuated in people with higher ejection fraction. The neurohumoral drugs have got a much clearer benefit in patients with reduced ejection fraction, but we don't see this with SGLT2 inhibitors. We see completely consistent benefit across the range of ejection fractions. So these drugs, really different, really unique, in this respect. And again, I think a breakthrough, because they're the first time that we've got strong, robust evidence of benefit for these patients with heart failure who've really been neglected until recently, because we've simply not had any convincing evidence from any treatment. And unusually, the European Society of Cardiology brought out, for the first time ever, a guideline update on heart failure. So they broke the normal 4 or 5 year cycle of guidelines to bring out this update to reflect this new evidence, because it was thought to be so important. And for both mildly reduced and preserved ejection fraction, once again, these new guidelines give the strongest possible recommendation, a class 1 level A recommendation. Now, I've focused a lot on reducing cardiovascular death, reducing heart failure hospitalization, but there are other goals of treatment. Improving symptoms and quality of life is very important. And again, in the DELIVER trial, we've shown this. This is improvement in a patient-reported outcome. So this is a questionnaire. Patients fill in 21 questions about their quality of life, about their symptoms, about their ability to do ordinary everyday activities. If the score increases, that's an improvement in health-related quality of life. If the score decreases, that's a deterioration. It's widely accepted that a 5-point change is a clinically meaningful change. You can see that people were significantly more likely to improve, significantly less likely to deteriorate by 5 points. But what has been really striking with these drugs is that we've seen these unprecedented large improvements with SGLT2 inhibitors. We've not seen this with any of the other drugs we've tested. We've seen significantly more people have a 10 and a 15-point improvement in their health-related quality of life with these drugs. So these treatments also make people feel better, which is very important. If you don't believe what the patients tell you, this is what the doctors in the DELIVER trial said. They were blind at treatment allocation. They didn't know what treatment patients were getting. And as you can see, NYHA class was significantly improved in patients receiving SGLT2 inhibitor therapy. NYHA class was significantly less likely to worsen in patients getting dapagliflozin compared to placebo. And again, you can see how quickly this difference emerged. The first time we repeated NYHA class assessment in the trial was after 4 weeks after randomization. And you can see already by that time, significantly more people had improved in the dapagliflozin compared to the placebo group. So whether it's the patient telling us or whether it's the physicians assessing the patients telling us, you can see this clear improvement. The other interesting thing in the DELIVER trial is that we looked at not just first heart failure hospitalizations, but we looked at recurrent heart failure hospitalizations, recognizing that patients with heart failure often suffer multiple admissions to hospital. And you can see here that total heart failure hospitalizations, along with cardiovascular death, were reduced significantly. And you can see, in fact, that at the end of the trial, these cumulative event curves were continuing to separate. So not only early separation, but continued separation at the end of the trial. And then finally, if we put these trials together, so in fact, we now have 5 SGLT2 inhibitor or SGLT1/2 inhibitor trials. There was another trial with sotagliflozin. You can see that there is significant reduction in cardiovascular death. And then lastly, the SGLT2 inhibitors have given us a new goal in patients with heart failure, and that is to preserve kidney function. Deterioration in kidney function is a terrible problem for those of us who treat patients with heart failure, because it often means we either can't give or maybe even have to withdraw other life-saving treatments like sacubitril valsartan or mineralocorticoid receptor antagonists. So if we could preserve kidney function, that would be great. And we now have evidence that SGLT2 inhibitors do that. Here you can see in the DELIVER trial, change in EGFR over time. The blue line are the placebo-treated patients. You can see this almost linear decline in EGFR over time. Sadly, something all too familiar to us looking after these patients. But this is what happens with an SGLT2 inhibitor. You get this initial small decline in EGFR. It partially reverses, and thereafter, the rate of decline is significantly attenuated. In fact, even before the end of the DELIVER trial, these EGFR slopes had crossed over and the placebo group had fallen below the dapagliflozin group. So suddenly we now know that it may be possible to actually preserve kidney function in our patients with heart failure. So to summarize and conclude this very rapid bird's eye overview, first of all, in heart failure, extremely consistent evidence of benefit. This is for our usual composite endpoint. This is our meta-analysis of the heart failure trial. This is where we are in 2024. We've got drugs that work remarkably quickly, have remarkable benefits, do all the things that we would want any treatment in heart failure to do, and are really well tolerated, and we believe very safe. And they are a real breakthrough, in particular for patients with mildly reduced and preserved ejection fraction who had no previous evidence-based effective treatment. So for heart failure, the message is very simple. Most patients are eligible for treatment with an SGLT2 inhibitor. There are very few exceptions, the main exception being people with type 1 diabetes. Obviously, people with a history of ketoacidosis, we generally will not treat with an SGLT2 inhibitor. We're still cautious in people with a very low EGFR. We have to watch people receiving insulin treatment more carefully, but it's not a contraindication, it's just a caution. We do have to advise patients, particularly men, about the risk of genital fungal infection, but that's very easily treated. We do have to be aware of the small risk of euglycemic ketoacidosis. Does happen, but it's not very common. We know who's at risk, and we know what we should do to minimize that risk, but this is our guidance. So finally, what has this whole 9-year journey with these molecules told us? Well, putting it all together, we now have 13 large trials at the time we published this meta-analysis in over 90,000 patients. I focused here on cardiovascular outcomes. Here's cardiovascular death or heart failure hospitalization. You can see that very clear, large benefit, very tight confidence intervals. Cardiovascular death, same thing, significant reduction in cardiovascular death, very tight confidence intervals. There's really no doubt that these drugs have been a breakthrough. And actually, I was at a meeting recently and somebody said these should be the molecule of the decade. And I thought that was a very good way to describe this breakthrough in these major branches of medicine. So with that, I'd like to thank you very much indeed for listening. I'd be happy to take any questions.
Thank you very much. Yes, sir. Please go ahead, sir.
Yeah, thank you very much, John. You said it was a bird's eye view. I think it was a panoramic overview of, something that is quite exciting from somebody who has been an integral part of the journey. So thank you very much. I'm sure there must be many, many questions.
Yes.
And I think somebody is handling the in-country moderators are handling the questions, is it?
And my
Yes.
apologies if I did diabetes or nephrology an injustice.
So, right, Professor Ugala, you have the Q&A link. Would you like to see the questions or?
Okay, fine. There are quite a number, so I'll probably have
Yeah, maybe you
look
can
and see
combine.
how some are in French, which I cannot. So, what are the long-term side effects of dapagliflozin, if any? We can start with that.
So the most common side effect are genital skin fungal infections, and I'm using those words very carefully because sometimes I hear people talk about genital urinary infections. We've looked at the trial data very carefully. There's no increase in risk of urinary tract infections. It's genital skin fungal infections. That's often an unfamiliar thing for men, particularly uncircumcised men. So you should warn male patients in particular about that risk, but it's easily treatable with an antifungal cream. Probably a lot less common in the patients I treat than in the patients my colleagues with diabetes treat. And the reason for that is that SGLT2 inhibitors really don't increase urinary glucose excretion very much if your EGFR is below 60. So, of course, many of our patients with heart failure have a low EGFR. They also don't increase urinary glucose excretion very much if you don't have type 2 diabetes. So many of our heart failure patients don't have type 2 diabetes. So I think the low incidence that we see of genital skin fungal infections reflects the EGFR profile and the often in many patients absence of type 2 diabetes. The other side effect I think is worth talking about is ketoacidosis, because that is the one serious side effect. And while it's uncommon, it does happen and you have to be aware of it. So I think you have to have a relatively high index of suspicion, and you do need to warn your patients. So if they're going for surgery, if they have diarrhea and vomiting, if they can't eat, particularly if they're on insulin or an insulin secretagogue, they are at risk of developing ketoacidosis, and temporary discontinuation of their SGLT2 inhibitor is appropriate in those particular circumstances. There are some things that we were worried about, but we've now eliminated as a real risk of these drugs. So there was at one point concern about amputations with canagliflozin. We think that's probably just one of those chance findings in one of the sets of trials. We've really not seen it at all since. There is also concern about the risk of something very unusual called Fournier's gangrene. But again, in the very large meta-analyses we've done in this collaboration that we now have with all the SGLT2 inhibitors, again, we've not seen an excess of that. So I think those are the main considerations. Doctors often ask about hypoglycemia, but again, I think unless you're on insulin or an insulin secretagogue, hypoglycemia is probably not an issue, and it certainly doesn't happen, for example, in our patients with heart failure who don't have type 2 diabetes and are not getting those types of drugs. But again, there are other people on the panel who may have a different perspective about that and who treat different patient populations.
Professor, thank you for them. Okay.
Go ahead. Yes.
Thank you, Professor, for this wonderful presentation. There are two questions from Zambia which I wanted to pose to you. The first question is somebody wants to know why you cardiologists keep prescribing dapagliflozin for patients with an eGFR of less than 20. So why do you cardiologists keep on prescribing if the medicine SGLT2 inhibitors when the SGLT2 is less than 20? And the second question, one wants you to give him which of those most drugs is most infectious in the treatment of heart failure, the treatment of CKD, and which of those SGLT2 inhibitors is more efficacious? Do you have differential efficacy of these medications when it comes to heart failure or CKD? Over to you, Prof.
Well, I'll answer that one because that's the easier one, I think, to answer. So as far as I'm concerned, is my personal opinion, the two SGLT2 inhibitors with the strongest evidence in CKD and in kidney disease are dapagliflozin and empagliflozin. Canagliflozin obviously has some evidence in chronic kidney disease. Sotagliflozin has some evidence in heart failure, but the strongest evidence and really the only SGLT2 inhibitors I see used in practice in my country are dapagliflozin and empagliflozin. And I don't think there's any difference between those. I think I tried to emphasize to you the consistency of the trials. So I don't want to get into a war comparing different drugs. I think we should celebrate that, to have trials where the hazard ratios are identical is just incredible. So I'm sure some people will point out that, in DAPA-HF, we saw a reduction in mortality. The Emperor reduced trial didn't. DAPA-CKD, there was a reduction in mortality. In EMPA-Kidney, there wasn't. But I honestly think the drugs are the same. The trials were different. The populations were different. The better way to look at the data is in a meta-analysis, look at the totality of the data and to look at the consistency of the effect. So I think that's my view. It's my own personal view, but that's the answer to that question. Now, the first question was an interesting one because I didn't know that cardiologists did keep prescribing SGLT2 inhibitors in people with an eGFR less than 20. I have to say that I do sometimes personally, but again, that's what I would call off-label prescribing. I'm not advocating it. And when I do it, I truthfully talk to my patients about it because I am then going beyond the evidence in heart failure. The reason I do it is because, along with my nephrology colleagues, we think there probably is still benefit from these drugs even below this arbitrary eGFR threshold of 20. And what we usually do, both in cardiology and nephrology, at least here in Glasgow, is we start in these patients' treatment under very close observation. We make sure the patient's eGFR doesn't decline too much. And if it does, we withdraw the treatment. But actually, you don't see that very often. And one of the interesting things that we haven't had time to talk about is that the eGFR decline tends to be smaller in people who start with a very low eGFR. So although you are often fearful initially when you start to use a drug like this in people with a low eGFR, what you find is that actually the initial decline in eGFR is maybe only 2 or 3 mils per minute. Don't forget that decline partially reverses. We don't know why that is, but in chronic kidney disease and in heart failure, you see that initial decline, but then eGFR tends to go up a bit. So often, if you check eGFR after sort of 2 weeks, that's what I would call nadir, the lowest point that it's likely to go to, and it may go back up. So I'm not advocating generally giving these drugs to people with an eGFR below 20, but sometimes you may be willing to do it. I would personally advocate discussing that with your patients so they know what you're doing and why you're doing it, and they know the potential risk of doing it. And if you are going to do it, I would advocate keeping a very close eye on them, checking their eGFR after 1 to 2 weeks and maybe again after 4 to 6 weeks. and only continuing, obviously, treatment if the EGFR hasn't dropped to an unacceptably low level, which I would define as somewhere between 15 and 10 mils per minute. But I'd be very interested to hear what our nephrology colleagues think about that. What do they do?
If I may just interject something there before the nephrology colleagues talks, there is a slight distinction between initiating in those with an EGFR of less than 20 and in those in whom you start at a higher level and then the EGFR dips down to below 20. I think there is some evidence from the trials that if the EGFR dips below 20, that it is beneficial to continue the SGLT2.
Oh, absolutely. That's true in heart failure trials as well. I mean, this dip in EGFR is it's simply a marker that the drug's doing what it's meant to do, that your patient's taking the drug, and it is associated with a better outcome. You're absolutely right about that.
Maybe we can hear something from the nephrology colleague.
Professor Lau? Yeah, you're on mute. Yes. Yeah.
Thank you, Chairman. As nephrologist in Madagascar, when dapagliflozin was introduced in Madagascar, we were worrying about misuse. And of course, there were misuses because we received many patients to who dapagliflozin was introduced when the patient was already in end-stage renal disease. And I agree completely with Professor McMurray when he says that the results are consistent because we didn't see that much adverse events. And it's like what's written in the papers. So this drug was simply quick spreading over the country, over the island of Madagascar, because of such good work done by the laboratory and not by the medical societies. And they didn't see so much adverse event. So I also agree to keep in dapagliflozin as long as the patient tolerate the dose introduced.
And that's what we did in the DAPA-CKD trial. So we even had people who continued treatment on dialysis. So we do have some evidence there, and I completely agree with you. That's what we do in practice.
Of course, it will not be to slower the course of renal disease for the patient is already at end stage, but for the cardiologic advantages and for other protections.
There is a question here about mechanism of benefit, renal protection, and being a cardiologist. Of course, I want to extend that question to why do we think these things work?
So that's the $1 million question. And so there are two ways to answer this. One is to avoid answering it by saying we don't really know how any drug acts. And to some extent, I do honestly take that view because I think what matters is it does act and that we've got very strong evidence that these drugs are beneficial. But in heart failure, I mean, we see favorable cardiac remodeling, we see correction of anemia, we see prevention of worsening kidney function. So it's probably not a single action. There are probably multiple actions. Some people believe that we change cardiac metabolism so that it's more favorable, that it's energetically more efficient. So even ketones may be important because they may be a better fuel, believe it or not, for the failing heart than glucose. So there's lots of potential benefits. One of the things we've reported from DAPHF is that we saw a reduction in sudden death. We saw a reduction in ventricular arrhythmias. There's a new study will be presented at this year's ESC confirming a reduction in ventricular arrhythmias. So like all of the drugs we use, probably multiple actions. in terms of chronic kidney disease, I'm the wrong person to answer that question. I do hear people talk about reduction in glomerular filtration, augmentation of tubular glomerular feedback, and so on. And that may or may not be relevant, particularly in patients with type 2 diabetes. But again, I suppose the point really is not so much how the treatment does it, but the remarkable finding in 3 large independent trials that you prevent progression to end-stage kidney disease. You reduce the risk going on dialysis. You reduce the risk of needing kidney transplantation. That, to me, is the important point. And mechanisms are interesting, but not patients not going to be very interested really in the mechanism of action. They're more interested in what the treatment can do for them. But I don't know, is there a nephrology perspective on how these drugs are nephroprotective?
Maybe Professor Loa. Can Professor Loa add something on that?
Excuse me, repeat your question.
Oh, why do you think SGLT2 inhibitors protect the kidney? What do you think the mechanism of renal protection, kidney protection is?
I think the main mechanism is of tubuloglomerular retroaction by lowering the pressure from afferent arterioles. And of course, tubuloglomerular retroaction. There are many supports by
I think there are two devices. Can one be put on mute, please?
Is it okay now?
Yes.
Yes.
Yes. And of course, the kidney take benefits also from the heart protection, the bettering of fraction ejection.
Yeah. And vice versa. So I think our patients, I mean, after all, what defines heart failure? It's sodium and water retention, congestion. So I think our patients obviously benefit from the kidney effects of these drugs.
There was a professor. There was a question about the dose of dapagliflozin vis-a-vis what was used in the studies and what we have on the market. Sometimes you have a 5 milligram tablet. Sometimes you have a 10 milligram tablet. And one doctor wants to know, I mean, who do you give the 5 milligrams? Who do you give the 10 milligrams? What factors do you consider? Do you consider weight? Do they have the same effect?
So, okay, so I'll give you a straight answer to that. So I use 10 milligrams. We use 10 milligrams in the trial. If you want to practice evidence-based medicine, you use 10 milligrams. We did have the option in DAPHF of back titrating to 5 milligrams. And I think it was something like 3 people back titrated the dose to 5 milligrams. So it was very uncommon for people to have a reduced dose of dapagliflozin in the DAPHF trial. So use 10 milligrams. That's the evidence-based dose. Why would you not use the evidence-based dose? It was extraordinarily well tolerated. I mean, I've been doing heart failure trials, unfortunately, too long, more than 25 years. And I do not know of any treatment as well tolerated as an SGLT2 inhibitor. So why not use the evidence-based dose? It's very easy. There's no dose titration. People tolerate it, 10 milligrams.
Prof, there is an interesting question here, partly because it is an area that I'm lately interested in, but also because it is very important in heart failure because of polypharmacy. So somebody is asking if there is any prospect of having a combined pill anytime in the near future.
Absolutely, there is. So I know of at least 2 pharmaceutical companies who are working on a combination of an MRA and an SGLT2 inhibitor, or alternatively, an aldosterone synthase inhibitor, which effectively does the same as an MRA and an SGLT2 inhibitor. And I'm sure there are more companies doing this in the background that I don't know about, but I certainly personally am involved or was involved in 2 trials using that particular combination. And I would love, and I think it's a really, really good question. I would love now to get a polypill for heart failure. I don't see why we shouldn't do it. We've lost our fear of introducing these drugs. I don't know if you remember, Elijah, you sound like you're doing this as long as I am. I can remember the days when ACE inhibitors were a drug people were terrified of. Patients used to get admitted to hospital to start an ACE inhibitor, and we've lost all of that fear. The new guidelines are telling us to start drugs together simultaneously, and we can do it. I do it all the time now, and generally it's fine. So I do think the time has come for a polypill for heart failure, and I'd love somebody to develop that. But the problem is, I don't know which companies are good at developing polypills.
And eating apples. Somebody wanted to know if
you have to eat the skin
to prevent heart failure in diabetic patients. And
you have to eat the skin. So the fluorescein is in the skin of the apple. Or drink cider, but that might be bad, because if you drink too much cider, you might cause heart failure.
And there's also another question on the prolongation of the QT interval. Somebody has HFrEF, and when you do the ECG, the ECG shows a prolonged QT interval. So I don't know. One wanted to know whether you can use SGLT2 inhibitors in such a patient who has a FREF, but has a prolonged QT interval when you do the ECG. So he wants to know, does the drug have effects on the QT interval?
So it does not have effects on the QT interval. And if you're interested, there will be a presentation at the ESC Congress in London in about 4 weeks' time, looking at the effect of dapagliflozin across the whole range of QT interval, QRS duration. We've got a whole analysis of effects according to baseline ECG findings, and I hate to use that word again, it's completely consistent. So dapagliflozin doesn't affect the QT interval. There's no reason why you wouldn't give it to somebody with prolonged QTC. I think the only thing I would be careful about in those patients is avoiding hypokalemia. Probably I'd try and make sure they're on a mineralocorticoid receptor antagonist as well, to ensure that I kept their potassium up.
I think Dr. Quanalo from Eldoret wanted to say something. Constantine, can you?
Probably I'd try and make sure they're on a mineralocorticoid receptor.
Go ahead. Wanted to say something. Constantine, can you?
Yeah, thank you, Prof. I have some 2 questions for Professor McMurray. The first one is there any role for primary prophylaxis?
Any role for primary prophylaxis? I didn't hear the rest of it. You mean using them as a primary preventive treatment?
There's a lot of echo here. I don't know what I'm not doing right.
You can close the other link.
Other
and
one,
only the
can
Zoom
you?
link.
Using S.
Using them as a primary preventive treatment.
Exactly. That's the first question.
Okay. So the diabetes trials I spoke about at the beginning, EMPA-REG outcome versus CV, declare TIMI 58 canvas. In a way, those were primary or secondary prevention trials in patients with type 2 diabetes. I mean, many patients in the Declare TIMI 58 trial had type 2 diabetes and cardiovascular risk factors, didn't have established cardiovascular disease. So in that sense, we know, at least in patients with type 2 diabetes, SGLT2 inhibitors used as primary preventive therapy do reduce the risk of incident heart failure. I personally don't think that they reduce the risk of myocardial infarction or stroke. So I think their preventive benefits are largely due to prevention of heart failure. What we don't know is about their preventive role, or at least primary preventive role, in patients without type 2 diabetes. So that's the kind of gap in our knowledge. And when it comes to thinking about patients with type 2 diabetes with risk factors but not established cardiovascular disease, if you were to give that patient the best possible primary preventive treatment, it would probably be the combination of an SGLT2 inhibitor and a GLP-1 receptor agonist. The SGLT2 inhibitor to reduce the risk of heart failure and kidney disease, and the GLP-1 receptor agonist to reduce the risk of stroke, myocardial infarction, and we now think kidney disease as well. So probably to maximize primary prevention in somebody with type 2 diabetes, it's both of those drugs. Now, whether that's true in people without type 2 diabetes, we don't really know. With GLP-1 receptor agonists, we've got some data in obese patients without type 2 diabetes showing preventive effects. We don't have that for SGLT2 inhibitors.
Prof, if I might just extend that question,
Yep.
I mean, for example, for ACE inhibitors, we have the solve prevention arm, so treatment of asymptomatic LV systolic dysfunction. Do we have anything on the pipeline for SGLT2 inhibitors in a similar population? If I might just extend.
No, we don't, although two trials I didn't talk about, mainly because I didn't have time, are the two recent myocardial infarction trials. So there was the Dapapride trial, which treated a low-risk population of patients with myocardial infarction, not surprisingly, didn't show anything. And then there was the MPACT MI trial, which was an empagliflozin trial in patients at higher risk after myocardial infarction. And in that trial, there was a reduction in heart failure hospitalizations because that trial targeted post-infarct patients who were at increased risk of developing heart failure. There was a 23% reduction in a first heart failure hospitalization. There was a 33% reduction in total heart failure hospitalizations in the MPACT MI trial. Now, the problem was those were not the primary endpoint. So technically, MPACT MI, we have to say, is a neutral trial. But I must say, if I'd been involved in running that trial, I would not have designed it the way it was designed or had the endpoints that it had, because realistically, I think the evidence is extremely clear. What these drugs really do well is prevent heart failure hospitalization. So the endpoint focus in those trials should have been heart failure events. And if that had been the primary endpoint, it would have been a very positive trial. So that's the nearest we've got to a sort of solve prevention type trial.
I have a question from a colleague from Madagascar. a cardiologist. He says, I am prescribing dapagliflozin in patients without heart failure but having COVID-19. COVID-19 with hypertension, preserved ejection fraction, but altered global longitudinal strains of -15%, high capillary pulmonary pressure, 20%, left ventricular preload in gray zone. What is your opinion about that?
So is the question about COVID-19, because if your patient's got heart failure, patient's got an indication for an SGLT2 inhibitor, there was, as you probably know, a lot of interest about whether these drugs would be actually a treatment for COVID-19, and they were studied in 3 large COVID-19 trials, but overall, the trials were neutral. There was no increased risk, but there was no significant reduction in risk. Now, I thought this was a crazy idea. I thought these people were mad to try giving an SGLT2 inhibitor to people with COVID-19. I thought they were going to see more ketoacidosis, that they could make things worse, but they didn't. The trials were overall neutral. There was suggestion of some types of benefit, but the trials were not significant. So all we know really is that these drugs certainly don't do harm to people with COVID-19. So I don't know, didn't hear the question so well, and I wasn't sure if it was about COVID-19 in a patient with heart failure or not. But we actually do have a lot of data, believe it or not, with these drugs in patients with COVID-19 showing that they're safe. And in fact, the DELIVER trial, so the trial in patients with heart failure and mildly reduced and preserved ejection fraction, we conducted that trial during COVID-19. Patients developed COVID-19 during the trial, but we still saw an overall benefit.
I think his concern was about the global longitudinal strain of -15% and the that was in gray zone.
Still, your sound is very bad. So I can hear a global longitudinal strain. And what was the other part?
-15%.
I hope my sound is better. I have the question here. I can read.
Okay. Thanks.
So it says, thank you very much for this presentation for the webinar. In my practice, I prescribe Dapapride.
Elijah, you turned your head away from the microphone.
Oh, okay, because I'm reading from a different screen. Okay, fine. Sorry.
What was the question?
In my practice, I prescribe DAPA in patients without heart failure, but having COVID-19 disease, plus hypertension, plus LV ejection fraction around 50%, plus altered global longitudinal strain -15%, plus capillary pulmonary pressure 20%.
20.
But LV,
it must be 20.
It's a difficult question. Okay. But LV preload in gray zone, what is your opinion? I'm not sure I understand it. I hope you understand it.
So it sounds to me this is a patient with mildly reduced or preserved ejection fraction, in which case there's an indication for an SGLT2 inhibitor. What I don't understand is the COVID-19 part of that. Should you give it in somebody who's got active COVID-19? I would say no. Is this about a patient who seems to have developed heart failure because of COVID-19? Well, it doesn't matter what the etiology is. SGLT2 inhibitors work across the range of etiologies. Are you worried about the safety of an SGLT2 inhibitor in case somebody catches COVID-19? No, because we've got a remarkably large safety database with SGLT2 inhibitors in COVID-19. So I don't know, I've tried to answer about 4 questions there because I wasn't quite sure what the specific question was.
Yeah, so Can we go to the panel discussion because country moderators are there? Can we start because they have their own burning question to ask Professor McMurray? Can we start with Mauritius?
I'm happy for people to ask each other questions.
Yeah. Can we have Mauritius, Professor Sukun? So can we start with Mauritius?
I don't have any question from Mauritius on my list.
Yes.
But
can
if you don't mind, I would like to translate for French-speaking people for the question from Professor Slouf. Chers confrères, donc d'après le professeur McMurray, la COVID-19, il n'y a pas de preuve d'intérêt de la prescription de dapagliflozine. À travers les études, il n'y a pas tellement d'intérêt. Mais par contre, si vous êtes convaincu qu'il y a une insuffisance cardiaque, bien sûr, c'est une indication de dapagliflozine. Et donc, c'est quelque part, ça vient donc à votre pratique de juger que le patient ou la patiente est en insuffisance cardiaque. Et donc, à ce moment-là, l'intérêt de dapagliflozine est bien instauré, bien reconnu, documenté. Thank you so much.
Yeah, thank you, sir. Dr. Sukur, can you ask questions from Mauritius, please? You're on mute. Can you unmute, please?
Thank you very much for this great talk. Just one quick question regarding some patients in Mauritius are using SGLT2 for weight loss reduction, non-diabetics in obesity. And some of them have fatty liver and they're actually seeing benefit from that. But would you endorse that sort of practice?
No, I wouldn't. SGLT2 inhibitors have very modest effect on weight. So in our trials, we saw average weight loss of maybe 2 kilograms roughly over around 2 years of follow-up. Some people had larger weight loss, but never more than maybe 5 kilograms. So very modest effect. And I mean, you're exposing yourself to well, I suppose we've never seen, I'm just trying to think, I don't think we've ever seen a single case of ketoacidosis in people without type 2 diabetes. So maybe you're not exposing yourself to the risk of ketoacidosis, but it just seems wrong to me to use a treatment where there's no indication for that. Now, I know that there has been some interest in SGLT2 inhibitors, obviously, potentially helping people with fatty liver, but I've never seen consistent, robust evidence of that. We've looked at transaminase levels and so on in our trials, and we've seen no improvement in any liver function test. So no, that's not necessarily people with fatty liver, but I'm not convinced that there is liver protection. And when I drew that slide, if you remember in my presentation of organ protection, I had the heart, I had the kidney, I had bone marrow, I had the pancreas. When I was thinking of drawing that slide, I was thinking about putting the liver into it, but I could not find good, consistent, reproducible evidence that there was hepatic protection, which is why the liver didn't feature in that. So I don't know if that helps.
Thank you very much.
Yeah. Are there any questions? Can we move to Kenya? Dr. Gugai, if you have a question, can you kindly ask Professor McMurray? Dr. Paul Gugai?
Thank you. Thank you. I have two questions. The first question is, can you help me
We are not able to hear.
First question is,
I'm very, very sorry, but Sorry, I apologize.
I can't hear.
We can't hear. Is there any way to put a question in the chat or?
No. I think there is an audio issue there. I think technical team can you look into that.
The message.
No. I think technical team, can you correct it so we will go back to Dr.
Patients that have dysfunction.
I don't think we are able to hear. I think by the time we connect, we'll go to Dr. James Kaimer. If you have questions, can you ask, please?
Thank you very much, Professor McMurray. And
you're very clear, very clear and easy to hear.
So we know that these drugs have revolutionized the management of heart failure and kidney failure. But, you know, the audience here in Uganda has some questions.
Sure.
The first one is in patients with recovering ejection fraction. So you've started them on, you know, the 4 pillars of heart failure, and the ejection fraction has moved from, say, you know, 25 to 50 to 60, and we've seen that happen in practice. There's a temptation to start then to remove medications.
No.
And and the question is, if you're tempted to do that, which one would you remove first and which one would you keep? And I know you're shaking your head, but
yeah.
I'm wondering.
So the video is working as well.
Yeah, maybe you could answer that and then we, ask something else.
Definitely. In fact, I'm tempted to add something. So one of the interesting things we found in the DELIVER trial, where we actually had a significant number of people with improved ejection fraction, was that they still benefited substantially from the addition of dapagliflozin. So if I saw a patient like that, I wouldn't hesitate in adding an SGLT2 inhibitor because I know from DELIVER that dapagliflozin really helped those individuals. So far from stopping things, I would definitely still want to make sure that they were put in an SGLT2 inhibitor. Now, if somebody's completely recovered their cardiac function, then, of course, just like in Uganda, here in Glasgow, we get patients saying, "Doctor, do I need to stay on those treatments?" And actually, the group that's most problematic for me in that respect are young women who've had peripartum cardiomyopathy. They always want to stop treatment. And, you know, there is a randomized trial called TREAD-HF that was a randomized withdrawal trial and showed that very quickly about a third of these patients showed deterioration in their clinical status and their cardiac function. And the thing I think when people ask me that question, I always make, again, from my own experience of doing this, is you might think to yourself, well, that doesn't matter. If we watch them carefully, we can restart their treatment. But actually, the problem is that in some of those patients, as I've seen, unfortunately, even when you restart their treatment, you may never get back to where you were before you stopped treatment. And I suspect if I had a big enough data set, probably actually there are people who die on withdrawal of treatment. So I really, really don't like to withdraw treatment. I think we've got evidence that you shouldn't withdraw treatment. Of course, there's always exceptions. So, you know, if I'm convinced that somebody had heart failure, systolic dysfunction because of a acute viral myocarditis, and they've completely recovered from that, I might be more inclined in that individual to cautiously withdraw the treatment if they want me to. What treatment would I leave to the end? It would definitely be a beta blocker because of all the treatments that show favorable reverse remodeling, The one that has the largest anti-remodeling effect is definitely a beta blocker. The one I suspect probably has the most anti-arrhythmic effect, can't prove it, but I suspect is probably a beta blocker. So I would probably, if you forced me to take away all but one treatment, the one I'd probably keep is a beta blocker. But now you're asking me to talk about non-evidence-based medicine, and I'm never comfortable doing that. And I would always plead with the patient, really beg them not to stop their treatment.
That's a fair answer, Prof. The other one is, you talked about initiating the medications for heart failure, the 4 pillars at the same time.
No, not all at the same time.
If possible, right?
Well, the guidelines say that, the American guidelines in particular. I'm not sure. I've never said that, and I've never done it because I still, maybe it's my problem, not the guideline problem, but I'm still not altogether convinced about starting all 4 treatments at once. I start 2 treatments at once quite regularly, but not all 4. So sorry, I said that, I didn't mean to say it.
And I think you share sentiments here. I think the sentiments here that you should start the treatments, in a slower manner. And the question therefore is, how do you usually start your therapy?
Okay.
Do you start with, with ANIs and then SGLT2 inhibitors, or do you?
When we thought about this, myself and Milton Packer wrote about this a few years back, and the first thing we thought would be an SGLT2 inhibitor and a beta blocker. And we thought, start those together. That's the most logical thing. Beta blockers sometimes cause a little bit of worsening, a bit of fluid retention. And SGLT2 inhibitor does the opposite. That seemed like the logical combination. But what we did was we got all our databases. We've got almost all the large trials and heart failure databases here in Glasgow, and we analyzed the effect of all the different treatments, and we put them together in every combination you can think of. And the most effective sequence was an MRA and an SGLT2 inhibitor. And what I've found in my own practice is that you can easily give that combination in many, many patients without any problem, because neither of them lower blood pressure very much in patients with heart failure. And usually, and of course, the SGLT2 inhibitor helps prevent renal dysfunction. The SGLT2 inhibitor helps prevent hyperkalemia. So this is an easy to use combination. It's usually well tolerated. Then I add 2 additional treatments. Probably my next treatment in most people is a beta blocker, and my last treatment in most people is sacubitril valsartan. I would change that. For example, if somebody had a high blood pressure, then I'd use sacubitril valsartan before I'd use a beta blocker. The reason I do it that way is that I think people tolerate sacubitril valsartan a bit better if you've already improved their overall condition. Sacubitril valsartan, as you know, that's my other baby. Dapagliflozin and sacubitril valsartan are like 2 of my children. I hate to have to choose between them, but I think sacubitril valsartan is a little harder to use. It is a little less well tolerated. Hypotension is a bit more common. And I think to have your patients optimally treated before you start sacubitril valsartan is probably the best thing. And with that, I'm going to ask the very nice lady who's running this meeting, can I go? Because I promised my wife that I would meet her at 7 o'clock, and it is 1 minute to 7. And I can see my phone has got lots of texts arriving on it, and I think I know who they're from.
I think just one question, sir. Dr. Paul Gogi, he's connected. Can we just ask him? He was there that time. We couldn't hear him.
Thank you very much. I think you've answered a number of the questions our attendants had asked, but there is one question about the dosage. Currently, we are seeing a dosage of empagliflozin going up to 20 milligrams. Is there data for that dosage?
So
and when do you?
I hate to say I don't. I don't have I ever. I'm not sure I've ever prescribed. Maybe I've prescribed once or twice. So I generally have not used empagliflozin. The only time I've increased the dose of empagliflozin in a patient on empagliflozin is in a patient with type 2 diabetes where their glycemic control is not very good. And there I've gone to a higher dose. I suspect it does not very much, but rather than have to think about adding another glucose lowering drug, or even worse, having to start insulin, then that's the situation where I would go to a higher dose of empagliflozin. Now, I'm coming at this from the perspective of a heart failure doctor. In EMPA-REG outcome, there was no evidence that a bigger dose of empagliflozin was better. In the EMPEROR-reduced and EMPEROR-preserved trials, the dose of empagliflozin used was 10 milligrams. That's the dose for heart failure. Maybe you'll get some more glucose reduction in a patient who's not well controlled by going to a bigger dose, but that's the only circumstance in which I personally have tried to use a larger dose. Generally, for empagliflozin in heart failure, it's 10 milligrams.
This last one question. Do you think we should have SGLT2 as the first line drugs in diabetes, considering type 2 diabetes in its nature is a cardiovascular risk disease?
Okay, well, I'm not a diabetologist, so it's not up to me to advise people. But if I had my way, if I was ruler of the world and these drugs cost very little money, then if you had type 2 diabetes, unquestionably, you would want to be in an SGLT2 inhibitor and a GLP-1 receptor agonist. You would want to be in both of those treatments to give you the best possible chance of avoiding cardiovascular disease. But unfortunately, in the real world, these drugs cost money. They're not available to everybody. And it is financial restrictions that are responsible for people not getting them. I think if they were inexpensive drugs, then of course, I don't think anybody would disagree with what I've said. Problem is that they cost money.
Thank you very much, John.
Okay, thank you. Good to speak to everybody again. Thank you very much indeed for attending. Bye-bye.
Thank you very much, sir. Sir, Professor Ogola, there are few questions. Can I request our moderators, global moderator chairperson to take because they've connected? Is it okay, sir?
Yes, that's fine.
Yeah, okay. Right. So can we move to the other country? So we had finished till now. So we move to now Professor Dr. We can ask Dr. Kwanalalu. Can you, if you have questions, you can post it, please. You can ask. Hello, can you hear us?
He's muted. We can maybe unmute Professor Janabi.
Yeah.
Professor Janabi, unmute.
Yeah, thanks. Can you hear me?
Yeah, we can.
Yes.
Yeah. Can you hear me?
We can hear you. Yes.
Okay. Thank you. I think from our side, literally all the questions have been answered. There's something about the combined pill, how to titrate the doses and everything. So most of the questions have been covered. I think for us from eastern part of Africa, one, we should just try to abide with guidelines because there's a lot of evidence which John McMurray showed us today. We have been presenting these studies. I think them in multiple meetings which we've had in our country. But I think something which is my personal observation missing, apart from using all these 4-5 guided pillars, so heart failure, kidney, and diabetes, which is really growing very, very much in our countries. Because if you look on Tanzania, now we are talking about almost 14%. We jumped from 2011, where we had only 500,000 patients, but our data today is almost 3 million. But having said that, me with the background of being a cardiologist, but I'm a very keen person recent years, lifestyle modification. So it's very good that drugs are doing pretty good. I think on top of that, we as clinicians, we have to emphasize lifestyle, because these drugs, per se, without combination of proper diet, exercising, they will really not work the way we see. You know, when you do this controlled trial, placebo controlled trial, there are a lot of things which are controlled, removed, the analysis and everything. But out there in the real field, we as clinicians have to take part to encourage patients. The drugs are available, but I like the last comment from Professor Mark. They are pretty expensive. They are not for everyone. And if you look on our guideline in Tanzania, we have EPA, the guideline. So the rest have to do it out of pocket. So I still believe we are reviewing our guideline. I believe DAPA will in the coming future. So, no comment from our side in Tanzania.
Thank you very much, sir. From Dr. Mohammed from Mombasa, do you have anything to ask and say to Dr. Mohammed? Can you hear us? Okay, doctor. Any questions from Eldoret, Kenya, from Dr. Aquanalo? Yeah. Please go ahead. Please go ahead.
Can you hear me?
Please go ahead. Yes, sir. Any questions or you would like to comment on anything, sir?
You can hear me?
Yes, we can hear you, sir.
Okay, great. Just somewhere into or echoing what Prof. Janabi mentioned, the phenotype of patients we see here with heart failure have other etiologies like valvular heart disease, some have infiltrative cardiomyopathies, and some have got severe underlying lung diseases, all of which were excluded the Dapapride and Emperor Abuse trials. I don't know what the experience is from my seniors, and I will tag Prof. Ogola about this kind of patients. Should we give them an SGLT2 inhibitor or we wait for evidence?
Okay, sir. Thank you very much. From Rwanda, Dr. Charlotte, anything to say or would like to ask?
Do I give a comment on
yes,
what?
Sir.
Because
please go.
I was
please.
asked to give a comment.
Yes, sir. Please go ahead, sir.
Yeah, I mean, as Dr. Aquanalo rightly says, the profile of heart failure in our environment is slightly different, although it is changing now. But really, the bottom line is if you have structural heart disease, this is not what these drugs are meant for. these were patients that were not included in the trials. And so the treatment for structural heart disease is correcting the underlying structural abnormality, whether it is congenital, whether it is valvular. Unfortunately, the circumstances in our environment is that these people come late when they are already in heart failure. So do we assume then that the person with rheumatic mitral regurgitation, but who now has an ejection fraction of 40% should be treated like any other HFrEF? Probably. And some of these, small subpopulations, if you like, will never be actually studied in a clinical trial. But if you have our usual rheumatic heart disease patient who is in florid heart failure, has got mitral regurgitation, but the ejection fraction is 65%, there's pathophysiologically, there's really no reason why that patient should be on an SGLT2 inhibitor. So it's a difficult question to answer, but when we are using clinical trials, we should be careful that we look at who was included in those clinical trials.
Yeah, thank you, sir. Yeah, madam, you would like to ask any question?
Yeah, thank you very much. Actually, most of question here were to Professor McMurray. It was about the trial. There was one question about the study population in the trials. If there were some participants with HIV, as those participants may have heart drugs which may be nephrotoxic, and what will be the impact of SGLT2 on their progress. So I think if there is any comment from the panelists, they can go on. Another question was about the weight, the impact of SGLT2 on the weight, as we don't have many options for the weight management, especially in type 2 diabetes. If you would recommend, based on the result of different trials, if you recommend the initiation of SGLT2 inhibitors in patients with obesity. Thank you. Over to you.
Maybe we can have one of our diabetes experts tackle the second question. I think actually Professor McMurray had, alluded to it. The fact that there is loss of weight, but it's pretty modest. But maybe one of our diabetologist colleagues can handle that.
Professor Gola, I think what studies have shown and what John McMurray was saying here, the maximum he absorbed was 2 kilos. It was about 1 kilo per year, and the extreme which went to 5 kilos. But about, I would comment on the obesity side. When you look of obesity, you are talking of insulin resistance. So you cannot control diabetes without controlling the weight, because once you have insulin resistance, this is where we have the biggest problem in our practice. Because what is insulin resistance? It's about having insulinemia, a lot of insulin, and dysfunctional receptors. So while we continue to pump our insulin from exterior, these patients are not responding. How can they respond? And the most misguiding thing which we see in our daily practice, our patients comes with the glucose, which we do random or fasting. It's 5 or 6. Of course, it's normal. It's normal. It's not because they're in control. It's normal because there's a lot of insulin in the body now, because it's not functioning. So we are missing that window. And that's why now, if you look on diabetes, the era of looking on glucose has really gone, the glucose paradigm, they call it. Now people are more interested how much insulin is inside the body. Unfortunately, we don't have a standardized assay which universally can be used because of multiple reasons. But the biggest take-home message, we should not stop by seeing a normal glucose level. I repeat, it's normal because there's a lot of insulin. And we all know now with the studies coming out, insulin is more detrimental than the glucose itself. First, it retains a lot of fluids inside. That's why people are having a lot of hypertension.
Maybe we can keep our comments short so that we give people, as many people as possible, an opportunity.
Yeah. Okay. So I think we just have to control the weight.
Yeah. So I think we are coming to the closing the session. Any final take-home message, Dr. Williams? Would you say from endocrinology perspective, take-home message before we close?
Thank you very much. Of course, there's so many factors that have been discussed as regard to heart failure and use of SGLT2 inhibitors. But for us in diabetes, there's so many things we consider before starting somebody on medicine. You need to phenotype your patient, and there's the ABCD approach which you use, the age of the patient, the beta cell function of the patient. I think Professor Janabi alluded to it a bit when you look at the beta cell circulatory function and many other things, the bone immuno health. And of course, there's a new term, the precision medicine in diabetes care. So day by day, management of diabetes is becoming more complex, but we need to study the diabetes problem in our countries. For example, for us in Uganda, we've tried to phenotype our patients, and we've come to realize that most of our patients, a good number of our patients, about more than 30% of our patients, actually don't have insulin resistance. They have problems with insulin secretion. And like Professor Janabi said, determining which test to use, we are somehow using this the C-peptide to tell us, most especially if patients are lean, they have lean diabetes, to help us, know which medications we are going to use. So a good number of our patients will be on insulin when you come to Uganda. And of course, another section will be on disease SGLT2 inhibitors if we risk profile them. So for now, for purposes of time, I'll stop there.
Yeah,
most of the aspects, talked about by my other colleagues.
Thank you so much, sir. Dr. Professor Low, from the nephrology perspective, take-home message.
Thank you so much, Dr. Panjula. Maybe I will speak in French for speaking French-speaking colleagues. Ok. Donc, chers collègues, en fait, je vais essayer peut-être de résumer l'ensemble de ce qu'on s'est dit ce soir avec le professeur Martin. C'est que, bon, il est revenu sur les avantages des inhibiteurs du SGLT2, qui étaient donc les avantages cardiaques, mais surtout les avantages rénaux, car finalement, c'est la néphrologie qui a gagné le plus en termes d'avantages avec ces molécules. Et souvent, c'était limité à des fractions d'éjection, à des débilitations globulaires sur la 20 litres par minute. Maintenant, on voit de plus en plus les intérêts des inhibiteurs de SGLT2, même chez des patients avec des débilitations plus bas. Et les études commencent avec les patients transplantés, etc. Et donc, les indications qui étaient limitées auparavant, avec les plus grandes études, commencent à s'élargir. Donc, finalement, ce sont des molécules qui n'ont pas fini d'étonner et qui vont continuer à nous étonner, sans parler en fait des avantages aussi sur la perte de poids. Et même si le contrôle glycémique, ce n'est pas du tout le groupe, la classe de médicaments qui a montré le plus d'avantages, c'est quand même aussi important. Et je crois que je résumerai sur ce qu'il a dit sur la partie association d'antidiabétiques, la plus protectrice. Il a dit surtout que SGLT2, inhibiteur de SGLT2, avec les GLP1, ce seraient les meilleurs avantages car effectivement, les inhibiteurs SGLT2 n'ont pas prouvé de protection cérébrale, tandis que les GLP1 étaient meilleurs donc, pour la protection cérébrale et pour le contrôle glycémique. Voilà ce que je retiendrai de cette soirée. Dr. Panjula, thank you again, and thanks to the Microlabs team for including us to this conference. And I hope we will have more conferences like this, sharing with different African countries, because here in Madagascar, we don't have much opportunities to talk to colleagues from Africa. And this was a very great opportunity. Thank you so much.
Thank you very much, sir. Thank you very much. Professor Ogala, as the global chairperson, can you sum it up, and then after that we will close. Over to you, sir.
Yeah, thank you very much again, and thanks to Microlabs for bringing us all together and for inviting Professor McMurray. Unfortunately, he's gone, so I can't thank him. If I were to probably summarize maybe what, for me, I consider the take-home messages, one is that probably thanks to the SGLT2 inhibitors, it has brought back home to us is something that we've known all along, but I think it has put it, sort of in the forefront, the interconnection between chronic kidney disease, diabetes, and heart failure or heart disease in general. And SGLT2 inhibitors offer us the opportunity to tackle all these things with a single molecule. The second point I want to stress is actually something that Dr. Kwanalo mentioned from in the comments from Eldoret, that not all heart failure is created equal. And therefore, we need to appropriately profile our patients with heart failure. If you have a patient who is having constrictive pericarditis, all the pharmacological agents in this world are not going to do anything, probably except for diuretic. If you have a young or elderly man with critical aortic stenosis in heart failure, pharmacological therapy is not going to help you. So we need to look at our patient, and like I said earlier in my earlier comment, look at your patient and say, would this patient have fitted in the clinical trials that we have talked about? Having said that, for the group of patients who fit into the profile of the patients that were in the clinical trials, it is an exciting time for heart failure. And all of us know from our clinical experience that these drugs really do make a difference to our patients, and we should offer them to our patients. And in our positions as leaders, we should also work within the wider society to make sure that they are more accessible to our patients. So thank you all very much for attending.
Thank you very much, sir. With this, we come to the close of the session. I thank Professor McMurray for a very insightful and excellent lecture, and Professor Ogola for helping us, conducting as a global chairperson. And really, it was wonderful of you to accept this, and for excellent moderation, and wonderfully conducted the session. Thank you very much, sir. And also, I would like to thank our global moderators, Dr. Williams, giving the diabetology expert reviews, and Dr. Lowe for giving nephrology. Thank you both very much for helping us in conducting this session as the moderators, global moderators. And I thank each of our regional moderators who helped us in conducting so many regions and taking the important burning question and putting across to the panel over here so that it helped the audience at large. Thank you, each one of you. And not last but not definitely least, I thank all our participants who made it a successful program merely because of their unique interactions, excellent participation, and asking wonderful questions so that it became highly interactive session. Thank you so very much for all of you for attending, and I once again thank our faculty for making it a very, very smooth, full, and highly scientific program. And I also take this opportunity to Microlab's entire marketing team headed by Mr. Sanjeev. So that all the things went very smoothly. So Dr. Mahima, Dr. Prabhu, everyone put in their effort and ensure that everything went on smoothly. Thank you very much. And our technical team also helped us in conducting this more smoothly. Thank you, our IT technical team. And thank you very much, all of you. And with this, I take the permission of the chairperson of global chairperson and the global moderator to close this session. Thank you all, and good night to all of you. Thank you.
Thank you very much and good night. I'm sure in India it's past sleeping time.
Yeah. Thank you, sir.
Bye.
Bye, sir.
Bye.
Bye, sir.